Southeast Health since the last time we did one of these. So we'll let the doctors, we'll introduce them and let each of them kind of give you a few minutes of sort of what they do, where they fit in the continuum of care of heart patients or cardiovascular care, and then we'll open it up to questions. One thing we're doing a little different, we do have a few audio-visual slides and things that the doctors brought with them, so it's not a formal PowerPoint presentation, but if they need to refer to something, we can flip some things up on the slides if it helps them answer a question. So, and once we start with the question and answer, I'll come around as you answer questions, and I'll kind of come, especially for the folks in the back, I'll come listen, and then what I'll do is I'll repeat the question to the microphone so that everybody can hear what the question was, and then we'll let the doctors answer. So anyway, we'll start here with Dr. Stanley Jomek, who is a cardiothoracic and vascular surgeon who just joined Southeast in October. And then we have Dr. Gabe Soto, who's a cardiologist and electrophysiologist who's been with us for a long time. Another new provider is Dr. Drew Satterfield, who's a family practice physician who is practicing at our clinic here in Cape at the West Campus. And he also practices a couple of days a week in his hometown of Dexter. Then we have Mary Beth Corrigan, who is a nurse practitioner, cardiovascular consultant, and she runs our heart failure clinic. She sees patients with heart failure in the hospital and then sees them back in the clinic. And then Debbie Leone is our director of cardiovascular outreach, who goes out into the region and does peripheral arterial disease screenings, other vascular screenings. We're doing heart smart screenings. She does some things with CPR. She does some smoking cessation classes. So I thought it'd be important to have her here so you can know what are some of the things we're doing out in the area to help you do the screenings and identify problems before they're serious and get you connected to the right providers. So we'll let Dr. Jomek start off and kind of explain sort of his role in cardiovascular care, and then we'll kind of go down the line.
I hope this mic works. Anyway, I'm very excited to be part of the Southeast Health team. I was at Poplar Bluff for 10 years, and I knew Dr. Soto then when I sent patients to him, and now I'm part of the team, and I really appreciate it. I think Southeast Hospital is just one of the friendliest places I've been, and people are very professional and at a very high level, so it's great. I'm just thrilled to be here. I do open heart surgery, I do bypass surgery and valve replacement surgery. I also do peripheral vascular work where I take care of aneurysms, stent aneurysms. We balloon angioplasty, blockages in legs. I clean out the carotid arteries to prevent strokes. We also do lung surgery to take out lung cancer. So basically take care of the heart when it needs surgery, and the lungs and the peripheral vascular.
Well, thank you, Stan. My name again is Gabe Soto. I've been here with Southeast Health for close to about 11 years now. And I will say we're all very happy to have Stan on board as well. I am a general cardiologist as well as what you would refer to as an electrophysiologist, or simply put, an electrician for the heart. So although I do general cardiology, I also do specialize in heart rhythm disorders, atrial fibrillation being among one of the more common heart rhythm disorders that we actually treat and see here. The options for atrial fibrillation management we'll be getting into a little bit later this evening, but they really begins with education and understanding what atrial fibrillation is and what the different treatment options are, which for some people involves medications, and for others more advanced therapies, such as catheter ablation, and actually some treatments also which Dr. Jomek and his colleagues perform as well, in terms of surgical ablation procedures when indicated. But again, we'll come into that a little bit more later on this evening, I'm sure.
Thanks, Dr. Soto. Drew Satterfield, I'm a family physician here in Cape and Dexter. Kind of where I fit into all this, I like to think that sometimes I'm the first person to see someone who has atrial fibrillation. They'll come into my clinic not really knowing what's going on, why their heart's beating fast, or they may really not have any symptoms at all, but we can go ahead and get the process started about treating AFib, starting appropriate medications, and then getting that patient to see cardiology or someone like Dr. Soda for further treatment.
I'm Mary Beth Corgan, and I'm a nurse practitioner, and I work with cardiovascular consultants, also some of our cardiologists, and I see patients in the morning at the hospital, and then in the afternoon I have a clinic, a heart failure clinic, and I see patients after they're discharged from the hospital, and I also do see patients, some patients I see on a weekly basis. I'm there every afternoon, so I see patients as add-ons if they're having difficulty with their heart failure. Where I fit into this, a large percentage of my patients do have atrial fibrillation. So.
And I'm Debbie Leone, and I'm a little bit different than these folks. I'm not a provider, but my primary role is cardiac outreach, which has got anything to do with community screenings, smoking cessation. I do one-on-one coaching for people who are trying to quit. A lot of CPR, a lot of education, a lot of schools and community groups and things like that, as well as anything to do with the quality in any of those cardiac areas. So tracking all the work that's done. And the closest thing I have to being part of EP or atrial fib is that my office is right outside his lab. Otherwise, it's all about community outreach.
Okay, well, we'll go ahead and open things up to questions.
So Mike, if I may, just so that we're all on the same page, it may be good if we spend a few moments just talking about what atrial fibrillation actually is, so we're all on the same page. So atrial fibrillation, as we all alluded to, is one of many different heart rhythm disorders that we treat. And to understand atrial fibrillation, it would probably help to understand a little bit about how the normal human heart actually works and is structured. So in the diagram behind me, we have a little cartoon representation of what our hearts look like. Our hearts are basically a pump, and it's a pump that's designed with 4 chambers. The 2 upper chambers are called the atria. There's a right atrium and a left atrium. And then the 2 bottom chambers are called the ventricles. Mike, if you could advance to the next one. So the atria function essentially as accessory chambers for the heart. Their main function is to receive blood from the rest of the body and from the lungs, and to help fill the ventricles, which are the main pumping chambers. The ventricles themselves are the main chambers that deliver blood to the lungs and to the rest of the body. And as the name implies, atrial fibrillation is a rhythm disorder that affects the upper chambers of the heart, or the atria. So if we consider what is a normal heart rhythm, something that we in medical jargonese often refer to as normal sinus rhythm. And that comes from the fact that we all have a natural God-given pacemaker that actually sits in the right atrium. It's an area of the heart that we refer to as the sinoatrial node. And in a normal healthy heart, it fires off like a beacon at a regular interval and really sets the normal heart rhythm and rate when we're quiet and resting and relaxed as we are this evening. It beats at a slow rate and increases appropriately as we get up and about and become more active. What atrial fibrillation represents is really the complete breakdown of any organized electrical activity within the atrium. It is usually initiated or set off by one or more areas of the heart that begin firing off in rapid bursts, and those rapid bursts essentially destabilize the electrical properties of the atria. In some cases that may last for very brief moments, but in people who have more advanced cardiac disease and whom the atria are not very stable electrically to begin with, that can set off prolonged episodes of atrial fibrillation that can last for quite some time, and in some cases indefinitely. We typically break atrial fibrillation down into one of 2 general categories. The first we call paroxysmal atrial fibrillation, sometimes just abbreviated PAF. And that's a variant in which people go in and out of atrial fibrillation on their own, with episodes typically lasting anywhere from a few minutes to a few hours, and in some cases even up to a few days, but never more than 7 days. For patients who have episodes where they either last longer than 7 days or they go in it and they stay in it until we do something to intervene, we call those individuals as having persistent atrial fibrillation. And quite often those patients will not actually go back into a normal rhythm until we do something to electrically reset the heart, such as what we do when we do a cardioversion. When you see paramedics or doctors on TV take the paddles out or some equivalent, what we're essentially doing is resetting the heart in the hope of being able to restore a normal rhythm. A little bit in terms about the just statistics of atrial fibrillation. It's estimated that about 1 in 9 Americans will actually experience atrial fibrillation at some point in their lifetime. So if we look around the room, there's a good chance that many of you either have or will get atrial fibrillation. We don't see it all that often in patients under the age of 65. The Centers for Disease Control estimates that about 2% of the US population under 65 has AFib. I think the youngest patient I've ever seen with atrial fibrillation was 17 years old. So can occur at any age. But above 65, the rates start to increase exponentially. And about 1 in 5 people by the time they hit age 80 will actually have atrial fibrillation. There are many things that can predispose people to developing atrial fibrillation, and that's where our primary care colleagues come in to help manage those risk factors in an effort to help minimize the chances of people maybe developing atrial fibrillation later on down the road. So, for example, what are some of the things that we know are strongly associated with developing atrial fibrillation? Well, one of the leading factors is actually obesity and being overweight. And several studies have now demonstrated that for every BMI is something we call body mass index, which is a measure or a ratio of your height to your weight. For every BMI point above your ideal body weight, your chances of developing atrial fibrillation actually goes up by about 5%. Obstructive sleep apnea, which is a sleeping disorder, and is also not that uncommon in this population, is a condition which is strongly associated with the development of atrial fibrillation and other more significant health risks later on down the road. High blood pressure also predisposes people to developing atrial fibrillation, as does diabetes, particularly if not well controlled. Now, it doesn't mean that if you have high blood pressure or you have diabetes that you'll get atrial fibrillation. But if you have these conditions and they're not treated adequately, the longer you have them and the less well controlled they are, the greater the risk that you will go on to develop atrial fibrillation later on down the road. And treating atrial fibrillation when you have these other conditions is very, very difficult and in some cases impossible unless you also treat the other conditions that people have as well. And that's where managing patients with atrial fibrillation is not just the job of just one physician, but it really is a team-based approach between cardiologists, primary care providers, other support staff like Mary Beth, and our surgical colleagues when we need them as well.
Okay, so was there anything else that any of you needed to hit before we open up for questions? Okay, the floor is yours. Yes, ma'am.
You often hear of children or younger people who have irregular heartbeats. How does that relate to that?
So the question is about children that are found to have irregular heartbeats and how that relates to what Dr. Soto's talking about.
So that is an excellent question. And one thing to understand is that an irregular heartbeat can be a sign of many, many different kinds of rhythm disorders. And atrial fibrillation can certainly be one of those causes, but it is by no means the only one. And if you were to actually look at the most likely cause of an irregular heartbeat in in somebody under the age of 50, it's more likely going to be due to what we refer to as either premature atrial or premature ventricular contractions, PACs and PVCs. And these are actually naturally occurring skip beats or extra beats that occur not from your heart's natural dominant pacemaker, but from little accessory pacemaker sites in our heart that we all have. And if I were to put a monitor on everybody in this room for 30 days, I will guarantee you everybody's going to have some PACs or PVCs that pop up from time to time. Most of us are fortunate in that we actually don't feel them, but some patients do. And whether or not you feel them has a lot to do upon how close your PACs or PVCs come to your preceding beat. And in some cases you may not feel it, but you may have the misfortune that a doctor or other provider may actually detect it and may mention something to you about it. And if it's not carefully explained, it can certainly cause a lot of apprehension. When we hear of an irregular heartbeat occur in somebody over the age of 60, that, again, may very well just be due to PACs and PVCs. They can occur throughout your life, and they actually do occur with increased frequency as we get older. But because of the increased frequency of atrial fibrillation, that's when we start to actually get a little bit more apprehensive and diligent just to try to make sure that that's not actually what is going on. So one of the things we probably didn't talk about but should also mention is why are we concerned about atrial fibrillation in the first place? It's not just about having a diagnosis, but it's about the consequence of that diagnosis. And the consequence of atrial fibrillation and what it means to an individual does actually vary. It doesn't necessarily mean the same thing to all patients. For somebody who is very young and otherwise has no significant heart disease, no diabetes, no high blood pressure, no vascular disease, it may very well be no more than just a nuisance condition. And any treatment that we would typically do would focus on symptom control. But when you're in atrial fibrillation, the atria are not effectively contracting. And as you get older and as you accumulate other risk factors for stroke, as it turns out, atrial fibrillation can actually be a significant contributing factor to having a stroke. And if you actually look at what are the underlying causes of stroke in the United States, atrial fibrillation probably accounts for at least 10%, and in some groups even more. So the things that increase the likelihood of you having a stroke if you have atrial fibrillation include things like high blood pressure, diabetes, a history of congestive heart failure, a history of peripheral vascular disease, being over the age of 65, and please don't take offense at what I'm about to say, if you're a woman as well, is also an independent risk factor. And other risk factors as well include underlying structural or valvular heart disease. If you have a degeneration or problem with some of your heart valves or an abnormal thickening of the heart muscle. So all of those things can increase your risk of having a stroke with atrial fibrillation. Mike, if you can go to the next slide. So, in people who are at a high enough risk, when they're in atrial fibrillation, they can develop little clots. And these are really, truly small clots of no more than maybe a millimeter or two in size. The problem is that when the clots get ejected from the heart, the most likely place where they're going to land is in the circulation to the brain. And the blood vessels in the brain are just not that big. So a very small clot has a potential for actually blocking off and knocking off blood flow to a large area. And that's why the strokes that are associated with atrial fibrillation, unfortunately, tend to be among the larger strokes that people can suffer. Now, for people who are at sufficient risk, there are steps that we can take to actually lower that risk. And the steps that we take include the use of what we call anticoagulants or blood thinning medications for people in whom they're appropriate. Most of you probably know somebody who, at least at some point, has been on a drug called Coumadin or warfarin. Although nowadays there are many other alternatives that we have. And in many cases, not to be a plug for one particular medication or another, but most of the newer agents that you have probably heard, such as Pradaxa, Xarelto, Eliquis, and Savesa, have generally been shown to be either as effective, if not more effective than Coumadin, and also to generally be safer. And so for many patients, especially nowadays, we use those medications as first-line medications. And for some medications in whom drugs are not an option, and really the main exclusion is if you have a high risk of having a bleeding-related complication. And as a blood-thinning agent, that's one of the downsides of these drugs, that they will increase your risk of bleeding. Usually in those who have some other predisposition to bleeding. And in those individuals, there are other options that we can consider. Many of these other options are mechanical interventions. Stan here and his colleagues, one of the things that they can do is they can actually cut off or close off a part of the left atrium where most of these clots tend to form. And there are other devices which are now on the market that help reduce the risk. Again, we don't really view these as being a freestanding alternative to blood thinning agents in patients who can tolerate them. But for those who can't, there are viable alternatives that we can use. The other issue with atrial fibrillation is that in certain populations, it does increase mortality, and particularly true in heart failure patients. And unfortunately, atrial fibrillation is very common in patients who have heart failure. So making sure that we treat atrial fibrillation appropriately, either in terms of being able to control heart rates, or ideally actually keep patients out of atrial fibrillation when they have heart failure, is important. As I mentioned before, the atrium are essentially an accessory chamber for the hearts. And for individuals who have a normal healthy heart, they can actually function very well without that accessory chamber function. But when your heart function is not good to begin with, say if you've had a large heart attack in the past or have heart failure for another reason, the heart is much more dependent upon that accessory chamber function. And so for those patients in particular, we tend to be more aggressive about trying to maintain and keep them in a normal rhythm when possible.
Okay, any other questions? Here we go.
Oh, okay. I was found to have something wrong other than being a woman back when I was in my 20s. And later, Dr. Lindsay found that I had atrial fib. Way back then, they were doing ablation for the flutter, but not the fib.
Mm-hmm.
And so we went in, and that's when he found out that it was the fib. And at the time, so that was probably when I was 40-ish, and I'm almost 66. He put me on flecainide twice a day. And I have done very, very well in keeping it controlled. I've never smoked, I've never been extremely overweight, never high blood pressure, more like low blood pressure, always exercised and stuff. But he told me when I get older that I needed to not be on the flecainide because it can cause sudden death.
Okay.
What's old?
So for the folks in the back,
I mean, I feel great. I feel it go in and out sometimes, but nothing like it ever used to.
Okay.
And I have since, probably 6 months ago, Dr. Rutter put me on Eliquis because they think I flicked a clot.
Okay.
And but other than that, I work. I know what can throw me into fibs, and I know not to do those things.
Okay.
But what's considered old? How do you know when something's working? Do you have an ablation just because?
Okay.
I don't know.
So you actually touched on a handful of excellent points there. So we'll try to kind of go through them one by one. Let's maybe try to organize it in the following way. So let's talk about what are our treatment options for trying to keep you out of atrial fibrillation. Medication certainly being one line of therapy. And I will be upfront and state that according to the current guidelines from the American College of Cardiology, the American Heart Association, and the European Society of Cardiology, for patients who have symptomatic atrial fibrillation, medical therapy is, generally speaking, first-line therapy in terms of what we should try. And when that doesn't work, or in certain select cases, we can consider more advanced options such as catheter ablation, which I can talk a little bit about, or surgical ablation. And there's no reason for me to talk about that, and we have an expert in that area sitting right next to me. So let's talk about medications. The medications that we typically use to actually try to keep people out of atrial fibrillation are classes of drugs that we refer to as antiarrhythmics. So as the name implies, antiarrhythmia, they're designed to actually help maintain a normal sinus rhythm. And in the United States, there's a handful of drugs which are currently available. They include flecainide, propafenone, sotalol, dronedarone, dofetilide, and amiodarone. And then one which we don't use all that often as well as one called disopyramide. But really those are the drugs which are currently available in the United States. Flecainide is a drug that's been around for a while and is actually, generally speaking, a very safe drug. And personally is one of the go-to drugs that I use, particularly in younger people. The issue with flecainide and its cousin drug, propafenone, is that in a small subgroup of patients, which actually is not that small in this country, but in a subgroup of patients, you can get into serious trouble with that drug. And that group of patients are those who have had a prior heart attack. So, once upon a time, there was a period where cardiologists would dispense flecainide much like Pez candy for any kind of rhythm disorder whatsoever. Not only atrial fibrillation, but things like PVCs, for example. And people who have heart attacks have very frequent PVCs. It's not uncommon, like if you take a nail to a carpenter, they have a hammer, they're going to slam the head of that nail with a hammer. So if a cardiologist saw PVCs, we used to think, hey, it's not normal, let's try to suppress it with drugs. And when they actually did one of the first clinical trials looking at the effects of flecainide in PVC suppression, actually found out that patients were dying when they were exposed to that drug. We now know, fast forwarding a couple decades later, that the reason for that is that people who've had a prior heart attack, their hearts are not electrically normal. And flecainide has an effect in destabilizing the heart of somebody who has had a prior heart attack and increasing their risk of sudden cardiac death. But for people who've never had a heart attack, it actually is a very safe drug with a very excellent track and safety record. I think the concern that was really brought to you is not so much that there's any cutoff age where no, we have to stop using it, as much as the fact that, again, in this country, as we get older, the likelihood of having heart disease and of having heart disease that may not be recognized starts to go up. So I would say that in patients who are probably over the age of 50 in whom flecainide is being used, the prescriber really does need to do a careful screen to make sure that the patient is not having any symptoms or has any other signs in an EKG or otherwise that suggest that they may have underlying heart disease that's not been recognized or treated. Because that would be a situation where that person could potentially get into trouble. But if you don't have heart disease, I have several patients in their 70s and 80s who are on flecainide. It's worked wonderfully for them, and they are tolerating it well. And for those individuals, it's a very safe drug. The one drug which I will say is probably one that we do seriously consider stopping, or the two drugs that I would say we seriously consider stopping as people move on through life, is flecainite's cousin, propafenone, as well as sotalol. And the reason for that is propafenone is a drug that in about 5 to 7% of the US population, they are what are called slow metabolizers, meaning they don't clear the drug from their system as effectively as the rest of the general population. And in those individuals, the levels of an intermediate metabolite of the drug can insidiously accumulate to very high levels, leading to profound drops in blood pressure and heart rate. Generally, I don't see that problem, or haven't seen that problem really in anybody below the age of 70, but I have had a couple of patients that I've seen over the years who've been on propafenone for decades, and all of a sudden come in with profound low blood pressure. And it's simply because they're a slow metabolizer that was never really picked up. And there's no test that we can do for that. So that's generally a drug I don't continue that much beyond that age range. Similarly, sotalol is a drug which is also very effective, but is a drug that is cleared by your kidneys. And again, as many of us move through life, our kidney function does often decline. And the accumulation of sotalol in your system can lead to certain electrical instabilities that are referred to as QT prolongation. Plus, the other issue with sotalol, as many of us get older, we tend to be on more and more medications. And many of these medications can potentially interact with sotalol and cause problems. So that's one of the reasons why we sometimes make medication changes for those reasons in certain individuals as they get older. If you look statistically at how well medications work over the long term, it's about 50-50. For 50% of patients who are started on medications, it will work for them for the long haul. And the other 50%, they will start to have ongoing breakthrough episodes of atrial fibrillation. And when that happens, that's when we have to discuss other treatment options. And for those patients who either fail medical therapy or who cannot tolerate medical therapy, or in certain select cases where they just don't want to be on medical therapy at all. So an example would be a commercial airline pilot or somebody who works as a firefighter or a police officer or having a breakthrough episode of atrial fibrillation. If they're very symptomatic, can have a significant impact in both their lives and the lives of those around them. For those individuals, we do offer catheter ablation as first-line therapy in some individuals. So what exactly is catheter ablation? So catheter ablation is actually a general term, much like surgery is a general term, that refers to treatments that we do on the heart muscle that tries to alter its electrical properties. And the specific kind of ablation that we do for atrial fibrillation is something that we call a pulmonary vein isolation. So a pulmonary vein isolation is a procedure that was developed now about 25 years ago, and was based on the observation that atrial fibrillation in the majority, not all, but in the majority of patients often rapid bursts, and that those sites tend to be concentrated in the pulmonary veins. So these are the veins that drain blood from our lungs into the left atrium. Most of us have 4 veins, although there's quite a bit of variation. Some people have 5 or 6, and some even more. And the idea behind doing a pulmonary vein isolation is to try to electrically isolate the veins and the spots within those veins that can serve as triggers for atrial fibrillation without actually disrupting blood flow. We could ask our surgical colleagues to simply cut the veins from the heart, but that really wouldn't be too conducive to survival and make you feel very well. So catheter ablation is an attempt to actually disrupt those signals from ever being able to leave the vein. Mike, can you go to the next one? So the treatment has evolved quite a bit over the years. The way we do it contemporaneously now is using a special catheter-based system where we go into the left atrium through a series of punctures in the veins in the leg. We introduce a special balloon-shaped catheter into the left atrium. And once inflated, we actually press that against the openings of each of the pulmonary veins. The balloon is filled with nitrous oxide, which as the gas expands actually cools the surface of the balloon to about minus 55 degrees centigrade. And once we press that against the opening of the veins, it's going to freeze up whatever tissue it makes contact with and create a nice even ring of scar tissue around those veins. We typically will do 3-minute applications to each vein, and we'll do 1 to 3 applications until we see no evidence of any electrical activity crossing in or out of the vein. Procedure time from start to finish, typically about 90 minutes. Once we're done, we do some additional testing to see if there are any triggers that we can provoke outside of the veins, and we can in about 10% of people. And if so, then we'll go ahead and target those secondary triggers as well. The success rates for catheter ablation depend somewhat upon what kind of atrial fibrillation you have, whether it's paroxysmal or whether it's persistent. For people who have paroxysmal atrial fibrillation, catheter ablation with a cryoballoon has a single treatment success rate of about 70%. Not 100%, but about a little over 2 out of 3. The effects usually are not immediate because when you stick a large size balloon and catheter like that in the heart, you tend to actually irritate the tissue quite a bit. And in the process of doing the ablation, you often create a lot of secondary triggers. So it is very common for people to continue to have breakthrough episodes of atrial fibrillation for really the first 90 days after one of these treatments. But after about 3 months, 70% of people are doing well. For the people who continue to have breakthrough episodes, it's because of one of 2 reasons. Either as the heart has gone through a healing process, they've developed little gaps in those scar lines that we created, or they have triggers outside the pulmonary veins that we couldn't create, that we couldn't provoke during the first treatment. So for those people who continue to have recurrent symptoms, we can offer a second treatment. We do it a little bit different than the first go around. The second time we go in, we carefully map where we ablated, and if we find any gaps in those areas, we actually fill them in with little radiofrequency pulses, which gives a little bit deeper tissue penetration and tends to seal things off pretty well. After 2 treatments, about 80% of people with paroxysmal atrial fibrillation are doing well. That also means if you do the math, 20% or 1 in 5 have undergone 2 surgeries and they're no better off. We refer to those individuals as non-responders. And those are individuals who appear to have triggers outside the pulmonary veins and whom a pulmonary vein isolation is not going to work. And the thing that's frustrating for both physicians and patients alike is the simple fact that nobody has developed a test yet that allows us to see where any individual's triggers are before we do the procedure or select them for a procedure. So we can't say, yeah, all of your triggers are in the pulmonary veins, so we should go ahead and definitely set you up, but no, your triggers are not in the pulmonary veins, let's not even consider it. All we can do is go through the motions of the treatments and then see where we stand afterwards. And yes, that is frustrating, but that is the state of where things stand nowadays. For persistent atrial fibrillation, things are not quite as good. And partly is because people who have persistent atrial fibrillation tend to have more diseased atria. They tend to have a lot more fibrosis. And it takes less to actually put them into atrial fibrillation. And once they go into it, they actually stay in it. So success rates with catheter ablation for atrial fibrillation are closer to about 50% with a single treatment. And with 2 or more treatments, up to about 70%. But longer term, the data for cryoballoon ablation, this was introduced in the United States in around 2011 with the 2nd generation system, which is what we're using right now, and come out a couple of years thereafter. But most of the studies that look at people with persistent atrial fibrillation going 10 years and beyond, about over half of those patients will develop recurrent atrial fibrillation later on down the road. So that's one of the things to understand about all of these treatments and to understand about atrial fibrillation. In the vast majority of cases, atrial fibrillation is a chronic disease, much like coronary artery disease or diabetes. And there are different treatment options. If you want to get in early ahead of the game, that starts off with lifestyle modifications and changing the things that you can control early in your life before you even get the disease in the process. So again, watching your weight, making sure your blood pressure and diabetes are controlled, treating sleep apnea if you have it. A couple of other factors that we didn't mention, alcohol consumption. Not a whole significant increase in terms of light alcohol consumption, but moderate and more there is a clear association with an increased risk of atrial fibrillation. There are some things which truly are reversible and which kind of fall outside of that. So when our surgical colleagues do open heart surgery on patients, again, that really ticks the heart off. And some studies have shown that about 1/3 of patients may have postoperative atrial fibrillation, but that doesn't mean you'll have it after everything heals up. And there are some other conditions which can lead to an acute flare-up or development of atrial fibrillation, such as hyperthyroidism or extreme abnormalities in your electrolytes, such as magnesium and potassium. Or in some cases in the setting of severe trauma or other acute illness. And those are a little bit different. Their atrial fibrillation is due to an acute insult to the heart in the setting of either injury, trauma, or surgery. And once you get them through whatever the acute insult is, their atrial fibrillation is not likely to recur. But that's the minority of cases. For the majority, again, it's a chronic condition. And in deciding treatment options, we kind of have to tailor things on a case-by-case basis for what helps control symptoms, but also meets realistic expectations for the quality of life that one wants and what one is willing to go through. The one other treatment that I didn't talk about, I will defer to Stan here, since he would be the expert on that, and that is a series of surgical ablation procedures, both the Cox Maze and Mini Maze procedures, as well as some other treatment options.
Yeah, like Dr. Soto said, one of the options at the time of open heart surgery for patients that have coronary artery disease or valve disease and also have atrial fibrillation, we can, at the time of surgery, not only bypass the blocked vessels or replace or repair the valve, but also if they have chronic atrial fibrillation, we can do a maze procedure, which means we have a kind of a device that we create cryo lesions where we freeze little lines in the atrium, the top chambers. There's specific areas that we can create kind of like fences around the atria to kind of box in the irregular, those spots that create the atrial fibrillation. We can box them out with creating, we freeze the tissue and create a scar, and then that kind of boxes in the electrical impulse so that the atrial fibrillation is cured. And the surgical cure rate is probably 70%, 60-70%. And then the other thing we can do at the time of surgery is the atrial appendage, which is like an ear off the left atrium. It's kind of like a teepee. We can put a blocker, basically a device that seals off that teepee, where basically most of the atrial clot forms in this part of the atrium. It's called the left atrial auricle, and that's a very quick procedure. It doesn't add much to the operation.
One other thing that I'll just quickly mention, simply because it often does come up in discussion, is the issue of what about a pacemaker? People often ask, well, why don't you just fix this with a pacemaker? So, contrary to popular misconception, a pacemaker cannot actually make your heart rhythm normal per se. In fact, a pacemaker really has just one function, and that's keeping your heart rate from going too low. So it is really not an effective treatment at all for atrial fibrillation. There have been a couple of small studies that have suggested that in the minority of patients, if you pace their heart at a little bit of a faster rate, you may suppress the episodes of atrial fibrillation to some degree, but the effect is really very minimal and certainly not something that you can predict ahead of time before you put a pacemaker in somebody. So it's not something that we commonly routinely do. The main role of a pacemaker therapy in somebody who has atrial fibrillation is in the extreme case where a patient has really failed all other treatment options and they remain very symptomatic from their atrial fibrillation. When you're in atrial fibrillation, again, the upper chambers are just firing away with high-frequency electrical impulses and just bombarding your main pumping chambers with electrical activity. And in many cases, that speeds up the heart rate in addition to making it very irregular. And it's the fast heart rate and the irregularity and for those patients who either fail medical and ablation therapy or surgical therapy, or who simply are not candidates for those for one reason or another, we can put in a pacemaker and then do a very simple procedure where we simply cut the natural electrical connection between the upper and lower chambers of the heart, or cut the connection between the atria and the ventricles. Now, it's important to understand that doesn't get rid of your atrial fibrillation. That's just basically like cutting the string to a helium balloon and letting it float away. You're basically, at that point, telling the atria, do what you want, I'm done with you. The atria will likely remain in atrial fibrillation indefinitely. But the main pumping chambers will now be controlled by the permanent electronic pacemaker system. So your heart rate will be very regular. And it will probably actually respond much more normally to your activity level. Most modern pacemakers have a little accelerometer, so they can actually tell in large what you're doing. So when you're resting in a chair, they'll be at a low rate of 60 or 70. As you get up and move about, they'll increase the heart rate accordingly. So for many patients who otherwise have atrial fibrillation that we can't control, it actually comes fairly close to restoring a semi-normal rhythm for them. But it's important to understand two things about that. One is that you're still in atrial fibrillation, so your risk of stroke, if you have a high enough risk, is still there. And because most of the patients when they go that route are certainly older and have multiple comorbidities or other diseases going on, most of those patients are still going to have to be on some kind of medical therapy for stroke prevention. And then the other thing is that once we do that, we are making you dependent upon that pacemaker. So once that connection is severed, you are dependent upon that device for every beat. And for that reason, that is not our first option. We typically reserve that again as an option of last resort when there are no other viable options or every other thing has been tried and failed.
Real question?
My question is, I'm 65 years old and thought I was in good health until 10 days ago. And I woke up in the night with AFib, came to the ER, was treated wonderfully, and I stabilized and I'm on medication. But should I prepare for ER trips in the future?
So once you have atrial fibrillation, again, assuming that there's not an obvious reversible cause like your thyroid level was sky high or some other derangement, once you have it, then you are going to be at increased risk of having it going forward. Now, one thing which I don't have, which I wish I did because it would make my life a lot easier, is a crystal ball. And so I can't look into the future, especially when you've only had one episode, and say when you might expect your next one. You may not have another episode for another 5 or 10 years, or you could have one tomorrow. It's really not going to be until you've had a few episodes and you get an idea for what the frequency is between them before you can kind of say with any sort of predictive ability what the likelihood of when you'll have another one is. Now, most patients with atrial fibrillation, when they initially present, will have paroxysmal atrial fibrillation. So they'll come out of it on their own. And most of the time, there's not really going to be anything the emergency room is going to do to actually accelerate that process. Now, if you come in and your heart rate's going very, very fast, they will certainly give you medication to try to slow your heart rate down. But the medication that they use, which is typically a drug called IV cardizem or diltiazem, doesn't do anything to get you out of atrial fibrillation any sooner. It just works to slow your heart rate down. And they're generally gonna, they either wait until you convert on your own, or they'll give us a call and then ask us, okay, what do we do? So, especially for patients who have converted on their own the first few times, I usually tell them, if you have a breakthrough episode at home, if you're otherwise tolerating it, you don't actually have to go to the emergency room. If you're having chest pain, if you're having shortness of breath, if you feel you're about to black out or otherwise in distress, yes, the emergency room is the right thing to do. But please don't drive yourself there. But if you're otherwise tolerating it reasonably well, there is nothing wrong with just writing it out. And you can talk with your doctor about having contingency plans. Like for many patients, we have plans in place, if you have a breakthrough episode, okay, here's a medication I don't want you to take necessarily every day, but if you have a breakthrough episode, here's a prescription for oral cardizem that you can take. And it'll have its effect within 1 to 2 hours of you taking the oral dose. And give yourself, again, depending upon the patient, 48 hours or 72 hours to convert on your own. The longer you go without converting, the less likely you are going to come. So for most patients who we try the write it out at home approach, I usually tell them if you're still on it after 72 hours, then give us a call and we'll have to probably make other arrangements. But we can usually do things much more convenient for patients, like having them come in electively for a cardioversion rather than trying to go through the ER. And usually if we do an elective cardioversion, we can usually have you in and out of the hospital, usually within about 90 minutes, a couple hours at the most, as opposed to the sometimes 4 or 5 hour tour that can be the ER. But again, that's for patients who tolerate atrial fibrillation fairly well. You have to remember that there are many, many patients out there who live with atrial fibrillation every day. And in fact, if you look at patients as a group with atrial fibrillation, all comers, 1/3 of them roughly have no symptoms whatsoever. It's picked up incidentally. And we know this actually from studies of patients who have pacemakers. Pacemakers are little black boxes that record everything your heart does. And they're all part of registries with centralized data collection these days. So we actually know that about 1/3 of patients who have pacemakers will pick up atrial fibrillation, and they won't have any idea that they have it if it wasn't for us telling them. And for patients who have chronic atrial fibrillation, they're in it continuously. And if your heart rate is controlled and if you're on medications appropriately for stroke prevention, if your risk is high enough, there's no reason you can't live with atrial fibrillation for decades and otherwise have a relatively normal life expectancy. So again, it's not necessarily an emergency to come to the emergency room as long as you're tolerating your episode when you have a breakthrough.
in so many instances, in like your conversations and just health magazines and whatever, and they're talking about medications and all, it talks about if you have heart disease or if you don't have heart disease. What constitutes heart disease?
High blood pressure, cholesterol, blockages, what?
Correct. Yeah, all the above. So high blood pressure, high cholesterol, coronary artery disease. There's kind of a broad spectrum that those.
Well, then
they're
everybody
trying-
probably has heart disease, right?
Quite a few people, yeah.
Because, I mean, so many people are treated for high blood pressure, they're treated for cholesterol, you know, the two common things that they jump on all the time.
Yeah, and the drug companies kind of use that as a broad term. It's kind of, we kind of more make the decision on, you know, when medicines are appropriate and that sort of thing. So it's kind of hard for everyone in the general population to kind of figure that out. But
As a surgeon, we consider heart disease to be either blockages in the coronary arteries, which is the most common cause of death in America. Coronary artery disease kills one person per minute in America per day. You know, one American dies per minute from coronary artery disease in America, and about 800,000 to 1 million people in America die per year from coronary artery disease, from heart attacks or sudden death from atrial fibrillation. The other heart disease that we treat is valvular heart disease, which is aortic stenosis or mitral regurgitation. Those are the two most common valves in the heart that we treat. Patients have to have treatment for surgically, the aortic valve or the mitral valve. And we at Southeast have a very good valve clinic that is coordinated with the cardiologists and the surgeons, where patients with valvular heart disease can be assessed by both specialties. The cardiologists handle valvular and coronary artery disease with medications and with interventions that can be done percutaneously, you know, through catheters. The cardiologist can take care of quite a lot of heart blockages with stents. But then if the blockages are too severe or in a bad location, they'll call the surgeon to talk it over and see maybe whether bypass surgery might be better. Similarly, in valvular heart disease, the cardiologist will initially treat the patients with medication, and then if it gets bad enough, they will call a surgical team in to look and see whether a repair or replacement of the valve can be possible. And one of the things that Southeast has that many hospitals don't have is the capability of replacing the aortic valve through a percutaneous approach, through a puncture similar to a heart stent. But it's a valve stent, and it's called a TAVR. And Southeast does quite a lot of them. I think we're going to do 3 this week. And basically it treats patients that are high risk surgical candidates for aortic stenosis. And it allows the patients to be treated that are too high risk to have their valve replaced with a stent. And the cardiology team at Southeast is very good at it. And as a surgeon, we back them up. But that's just kind of an example of the heart team approach that we have at Southeast. We have a combination of cardiologists and surgeons that usually get involved with the patient's care and discusses the patient. Because each patient is different and each patient has complex issues, usually that have to be optimized as to what's best for that patient, because nobody is, every patient is a little different, and to give the patient the best treatment, it really is good to have a heart team. And that's one of the things I like about Southeast as as opposed to other places I was at, you know, things were more, this is my territory and I'm going to take care of this. This is your territory, you stay over there. Whereas at Southeast, we're colleagues and we say, come on over here, let's talk about this. Review the patient and try to do our best for the patient.
Just one quick word with respect to categories of heart disease or valve disease and what you may or may not have. It really is something that, if you're concerned, you need to talk one-on-one with a physician provider or other healthcare provider, because a lot of the terminology is intermingled and somewhat muffed up. So I'll give you an example. Again, going back to the anticoagulation options for atrial fibrillation. So beyond warfarin, as I mentioned before, there are several drugs, Pradaxa, Xarelto, Eliquis, and Sevaso, which I'm sure all of you have heard. And you've also heard, if you've seen any of those commercials or read any of those advertisements, that all these drugs are approved for use in non-valvular atrial fibrillation. Well, what exactly does non-valvular atrial fibrillation mean? That actually has been an area of confusion even among many physician providers. So as far as the FDA and as far as the definitions and all the studies that looked at trials go, valvular atrial fibrillation refers to patients who have severe mitral stenosis or who have a mechanical aortic or mitral valve. But if you have a bioprosthetic or a tissue valve, if you have mitral regurgitation, aortic regurgitation, or tricuspid regurgitation, you know, all those are different forms of valvular heart disease, but all of those medications are approved for use in those patients. So it really has to do with just, again, talking to providers one-on-one to address specific questions. Not to say anything against the lawyers in the world. My sister's a lawyer and I love her. But they've made a heck of a mess in some of the jargons and advertisements they do these days.
Okay, we're getting kind of late here, so I think we have time for one more question.
Hi, we have a 72-year-old family member who had cardioversion on Christmas Eve, and she went back to see the doctor. She hasn't had any chest pain, but I was wondering, at 72, even without symptoms, should they look closer at her heart?
Yes and no. So it's a little bit hard to answer that without actually knowing, for example, how close the physical exam and history was. You can actually gain quite a lot of information from somebody by just listening to them and by doing a very careful and thoughtful exam. And sometimes it's an art that is lost these days. But, you know, if you have somebody who you've done a thorough exam and they're completely normal and benign, and it's somebody who, even at 72, is very active, and they tell you that they're going out for their 5K runs every weekend, you know what, there's probably a good chance that from a heart standpoint, any testing you're going to do is going to be completely normal. And there probably is not any indication for doing any more testing in that individual. But if you don't have that information in hand, you know, you do want to make sure that if there are any doubts as to whether or not they have underlying structural problems with their heart, or if it's somebody that's not very active, for example, or you're not sure if you hear murmur, there are other tests that may certainly be appropriate under certain circumstances. So one thing that often comes up is, for example, do you need to do a stress test on somebody who has atrial fibrillation? I mean, there is an association between having heart disease and being at an increased risk of atrial fibrillation. But just because you have atrial fibrillation doesn't mean that you actually have heart disease. And there was actually a period of time where a large proportion of the stress tests that were being done in this country were actually being done on patients with newly diagnosed atrial fibrillation. The American College of Cardiology eventually put a stop to that and quite forcefully said, if you're not having any symptoms of heart disease, there is no indication for doing a stress test in all these patients, because it's not going to change what you're going to do management-wise, and most of the time you're going to do more harm than good by doing tests that actually have a fairly high false positive rate, and then it's going to lead to additional testing where you may actually start doing some real harm to patients. So again, everybody who is found to have atrial fibrillation deserves a thorough looks-over, with that involving the physician's eyes and ears and listening to the patient and examining them carefully. And what we may do beyond that, again, depends on each individual.
Okay, out of respect for the time of the panel, I think we'll cut it off there. I do want to have Debbie mention to you very quickly, since she sets up screenings out in the area that you can go to try to pick up some of these things and then get referred back to primary care or to cardiology. She can tell you about that. But another, just a reminder, as Dr. Zomek was so emphatic about the team approach, is that with all these folks being in Southeast Health and being on the same electronic medical record system, when you go to see Dr. Soto or Dr. Zomek, and then if you go back to see your primary care doctor, Dr. Satterfield, he has access to all that same information because they're all in the same system. So that really helps integrate that. But let's let Debbie tell you a little bit about the upcoming screenings. Then we're going to draw for your home blood pressure monitor, so don't be too quick to run away.
All right, the things that we have scheduled right now, we have several different screenings that we do. One of them is, we call it a vascular screening, and that is where we work with another company that comes in and we do it's the carotids, the aortic aneurysm, and the peripheral artery disease. That has a minimal charge that they charge, simply pass on to you, but we do those screenings. So those are scheduled for April 3rd, 4th, and 5th. Those marketing is not out yet, so you haven't seen it, but the 5th will be in Cape, and the 3rd and the 4th will be outside the region, Perryville and Sykeston, most likely. So those are the vascular, and we do those about 3 times a year. We are also getting back on board, we're excited to say, with our calcium scoring and lung screening. That will be March 23rd. Again, watch for that. Again, we'll have a nominal charge for it, but that will be done at the hospital. And that is for people, the lung screening is for people who have been smokers and are over between 55 and 77 years old and have have not already been diagnosed with lung cancer. And the calcium scoring or the heart screening those are CT exams. Those are people greater than 35 with a risk factor for heart disease, which, as you said, it can be very vague, and who have not already had a cardiac angiogram or a bypass surgery. The other one that we do, which is a free screening, is ankle brachial index, which is a PAD screening for people who may have issues with circulation in their legs. And those are done all throughout the region. I will have those on the calendar scheduled starting the end of April, and then they're done quarterly all over the place. So we do those quite a bit. The other one I'm going to put a quick plug for is if you do have a person who's trying to quit smoking, please do get in touch with us. I do a lot of one-on-one, and we look for how to help people quit the best way they can, and do it on their schedule, and I'll be anytime, anywhere.
Before we do the drawing, let's just give a hand to our panel and appreciation for their time and their expertise. I'll let Debbie do the honor of reaching and pulling out a ticket.
All right.
And some of the panel may be able to stay around for just a little bit if you have some other questions.
Ready? All right. Here's the number. 278. I bet a lot of you matched that, right? 278. 088.
Is that the first three?
Yep. First three are 278 088.
Oh, we have a winner.
088.
278. Well, you can't say you never win anything now.
Yep.
All right, folks. Thank you all again for coming out and making this event such a success. We appreciate it. Be careful going home.